Good evening to everybody. I'm glad so many people are here. I think this is going to be a very interesting talk. Yeah, this is the 8th Neuro Talk Evening. Today's topic is heart-brain interactions of love and death. And this is presented by Professor Dr. Arno Vilringer from the Max Planck Institute. So one of his jobs is the Max Planck Institute. You're going to see in just a minute. So, uh, can you see? Now you see me switching slides. So Professor Dr. Vilringer is the director of the Department of Neurology of the Max Planck Institute, as mentioned. The Institute for Human Cognitive and Brain Science, and also for the Clinic of Cognitive Neurology at the University Hospital of Leipzig. He's a neurologist, neuroscientist with earlier stations at the University of Freiburg, Harvard Medical School, Ludwig-Maximilian University of Munich, the Charité in Berlin, and since 2007, he's also an honorary professor. He's the co-founder and a speaker of two graduate schools, the Berlin School of Mind and Brain and the Germany-wide Max Planck School of Cognition. You can see the links right here. His research focuses on cognition, emotions, brain-body interactions, and the underlying development of stroke and dementia, as well as new methods for recovery after stroke. And just to give a small introduction to the topic, sadly you can't see my slides. In our day-to-day life, one of the most important connections, or the most important connection, is what we really never think of, because we don't think about breathing, we don't think about the connection from our brain to our heart. But what are we capable of if we consider it, and what is to consider if we use those connections? And this is the point where I would like to end my presentation and hand over to you, Professor Vilringer.
Yeah, thank you very much. It's a pleasure to be with you. And before I start talking, I would like to encourage you to interrupt or put something in the chat if there is anything that I don't explain well, or you think it's illogical, or you don't believe it, or anything. So of course, the main discussion is better if it's in the end, but especially if during one of the things that I mention, you're not happy, or you feel something should be said or asked, please be free to interrupt. I think it's best to do it in the chat, and because for me it's not so easy to follow the chat, but then Sebastian, for example, might just read the chat and then tell me to address you. Okay, so let's start. What you see here are three women. They are the relaxed evening discussing what produces emotion. The one woman is a cardiologist, the other woman is a neurologist, and the third woman is an engineer. And the cardiologist says it's very clear. I mean, obviously emotions are produced in the heart. The neurologist said, come on, you're stupid. 100 years of neuroscience has shown that all emotions, all mental activity is produced in the brain. And the engineer says, I don't know, I'm not an expert here, but if you give me signals, anything that reflects activity in the heart and in the brain, and then we can look at emotions, then I will tell you whether it's the heart or the brain. And this experiment has been done, and I will show you later the result. Basically, the overall question is, does mental function involve the heart? Does heart function involve the brain? And this is what I want to address in my talk. And on an even wider picture, and also with clinical implications, what you see on the left is René Descartes. And you probably know that René Descartes was kind of the person who had this idea of dualism, that basically the material and the mental world are completely separate, and that he had all these theories how they would come together in some part of the brain. But as you probably also know, most philosophers, most people would no longer think that dualism is any valid scientific option. However, although most scientists would discard it, if you go into medicine in a hospital to your doctor, then quite often you will experience profound aspects of dualism. So, because in hospitals, in medicine, we differentiate between diseases of the body internal medicine, mostly disease of the kidney, of the heart, or whatever. And we strictly separate them from mental diseases. And although, as I said, people would no longer believe in dualism, but they are typically completely separate. And often people go to the doctor and then the doctor says, oh, I have not found anything structural or anything in the body, so it must be, in German they say seelisch, as if it were a completely different world. However, if you look at diseases of, so to speak, of the soul, like depression and anxiety, and look at diseases of, for example, the heart and cardiovascular diseases, which are heart disease, stroke, and other diseases of the cardiovascular system, then they very, very often co-occur. So if you have one of those, then the likelihood that you have the other is often by a factor of 2 or 3 higher. And knowing that all these diseases are very frequent, so 20% of all people will suffer a stroke in their life. And if they have a risk of 3 times higher to become depressed, then you see that these are dramatic figures. And the question is, why is this the case? So why are these mental disorders and the cardiovascular disorders so frequently coinciding? And this is also a thing that I would like to address in my talk. And so the overall question today is, what is the relationship between the bodily and mental function in normal, healthy physiology and also in disease? And I will focus on the heart as one important part of the body, but it's just at one aspect which I'm looking at. I could also look at others, but that's a different topic. And I will look at heart-brain interactions and also in the context of emotions, love, and death. So in my talk, I will talk first about heart, emotions, cognition. I will then talk a bit more into the clinical domain about cardiovascular and neuropsychiatric diseases. And finally, I will try to put the things that I have supported with data before into some conceptual overarching concepts. So let's start with heart, emotions, cognition. And I mentioned it in the very beginning, the discussion of the 3 women. Is there a role of the heart and the cardiovascular system in general for mental functions? And I will first discuss potential role for emotions to answer the question. So the engineer said, give me signals. And what is a signal of the heart? A signal of the heart is the heart frequency, or the ECG, the electrocardiogram. What is a signal of the brain? The EEG, the electroencephalogram. And in this study, which basically does what these women wanted, emotions were elicited, different kinds of emotions. And simultaneously, these authors recorded ECG and EEG. And then they used advanced machine learning to predict from only the ECG signal and only the EEG signal, respectively, which emotion was elicited. So the emotions that were to discriminate were happy, angry, and sad. The measures were ECG, also another cardiovascular measure, plethysmogram, not so important, and EEG on the neural side. And interestingly, if you look at the classification accuracy based on the ECG, it's 76%. If you look at EEG, it's basically the same. In other words, this experiment shows that obviously you can read the emotions from both types of signals, and one might conclude that maybe both are somehow involved in producing emotions. Now, what is the underlying reason? So in this study, people elicited emotions and continuously measured changes in heart rate. And you see during the different emotions, happy, sad, angry, there are differential changes, and you see it also here. Can you see my cursor, actually? Can you see it?
Yes, we can.
Okay, so that's good. So you see differential changes in heart frequency, and that's basically the reason why you then can also differentiate between the different emotions based on an ECG. There are many other examples. I just give you some examples. So, for example, if you do a visual discrimination task in a threatening or a safe condition, you will have an immediate drop in heart frequency which differs between threat and safe. Or if you observe faces. In this study, people had to look at faces of loved, familiar people like the spouse, girlfriend, boyfriend, whatever, or neutral person. Then you can see that the heart rate reaction to loved ones is clearly different from neutral people. And even so, it's clear when you see faces, and it's even different when you just hear the name of somebody you are close to, whether you are neutral to. And there are many other examples, and basically they always go in parallel. If you now look at the regulation, what you learn in textbooks of the heartbeat and the blood pressure, then at first in the textbook, especially the medical textbooks, you see that the heart and the brain are connected by the parasympathetic and sympathetic nervous system, and but the origin of the parasympathetic and sympathetic system is mostly seen in the brainstem, which is unconscious and not known to be related to emotions. But in recent years, when people were eliciting emotions and looking at what regulates blood pressure, they found, and that's a study of us, we found the amygdala being involved in the regulation of blood pressure. Then people found also the ACC, the anterior cingulum, to be involved in the regulation of blood pressure and heart rate. And also the insula is known to be involved. And so now the picture of regulation of blood pressure and also heart rate has to be complemented by regions in the forebrain, like the insula, the anterior cingulate, and the amygdala. And we also know that these happen to be regions that from many other studies, we know that they are all involved in emotions. So if you hear this, then it's not a surprise that if blood pressure and cardiovascular regulation in general, if they are involved in the same regions are involved in emotions and in their regulation, maybe they happen to be systematically correlated. And especially if you study psychology, then you have heard of the James Lange theory, which basically, a bit counterintuitively, states that emotions are not originated in the brain, but basically it's the physiological arousal, like heart rate and other aspects of physiological arousal, that starts the experience of emotions. And this theory has been controversially discussed many, many years, 100 years, and the major problem why it has not been really resolved is that it's very difficult to separate neural activity and cardiac activity completely. So to have only one of the activity and then the other one. But in a recent study, I'm referring to the one on the right side by Su et al. In Nature, they precisely achieved that. This is an animal experiment. And in this experiment, they used so-called optogenetic, and this allows non-invasively to selectively change the heart rate. So as if to a value in the rats, as if the rats were fearful. And the idea was, so if the state of fear depends or starts in the periphery, then the animals, if you start changing the heart frequency by a strong value, then you should also elicit the emotion of fear. Interestingly, this was only partly the case. They found the change in the typical behavior of fear only in a certain situation when the rats were in a threatening condition, but not when they were in a relaxed condition. And the authors also showed that if they inhibited a certain brain area, the posterior insula, then the animal, even if they had this increased heart rate, did not become fearful. But if they were in a threatening condition, they became fearful when you just changed the heart rate. In other words, what does it mean? The conclusion is fear can be initiated in the heart and the brain, but it's shaped by their interaction. And the posterior insula mediates the bottom-up cardiac information and the interoceptive processing. In a more general fashion, both the body and the brain must be considered together to understand the origins of emotional or affective states. The other study which I mentioned has a similar finding. It's a group in Munich. They actually showed that when you have fearful emotions, that the feedback of the heart actually changes the amount of fear and the way fear is balanced. But both, the message is the same in both. You need both an input from the body and the brain to basically understand the precise shaping of emotions. Now, coming back to regulations and how the body and the brain relates and how this relates to emotions, let me give you a more general picture at first about how we think that heart rate and blood pressure are regulated. Classically, we think of it like you see on this picture. So classically, we think people have a certain heart rate or blood pressure, and this is measured in the brainstem with so-called baroreceptors. And if the blood pressure, and there's a set point, so the brainstem says blood pressure, the systolic blood pressure has to be 120. And if that set point is, if the true pressure is higher, then there's a reaction. And if the true pressure is lower, then there's a reaction in the other direction. Nowadays, we no longer think only of these set points which are supposedly in the brainstem, but we think of a model where actually the brain predicts heart rate and blood pressure. So we have representation neurons in the brainstem. They make some prediction, and if the prediction is met, all is fine. If not, there's an error, which then goes up again, and then there will be a correction. But interestingly, this does not end in the brainstem, but it goes to higher areas. And in higher areas, this feeling of bodily events is translated in more abstract thoughts and emotions. And at the highest areas, basically out of such feelings of heart rate or blood pressure or other bodily inputs are translated into changes in my bodily emotions. That, roughly speaking, is a more modern picture. I will come back to that later. And what this means is that now a more general picture, we have events in the body, we have events in the brainstem, and we have events in the brain, and they, via this mechanism, they instantaneously always interact. And that's the reason why, for example, if we have some emotions, we will always have also changes in the body and vice versa. But I will tell you more about this in a second. So, so far I have talked about emotions. Now, the question is, are there other mental functions which might also be influenced or might also influence the heart? For example, perception, learning, and other things. Here you see, for example, a study on somatosensory tactile function. So people get a tactile stimulus to the finger, they feel something, and these, what you see here, those orange areas, these are brain areas that are activated when people feel consciously a stimulus. But when we started at looking at the heart simultaneously, we were surprised that whenever people felt a stimulus, they also had a change in the heart rate, as you see here. And initially, we also noted that the change in heart rate, actually a slowing, is more pronounced when people consciously feel the stimulus as opposed to when they don't feel the stimulus. And so we thought, oh, that's a marker of conscious perception. Later, we noted it's not a marker of perception, but the change in the heart rate depends on my feeling of confidence, whether I'm very confident that I have felt the stimulus or not. One has to mention that these stimuli were very weak. So you have to convince yourself that you feel them, so-called near threshold stimuli. And if you are not confident, if you are unsure, then your heart rate changes. So this feeling translates into a change in the heart rate. But not only the feeling of unconfidence or tactile stimulation. Also, don't want to go into this. These are other studies, older studies. The slides are not that nice. But what people show is whether you are touched, whether you are touching yourself or whether somebody else touches you also differentially relates to a change in the heart rate. Or similar here, there are touches by some robot or a social touch by somebody you know. Then this also will differentially affect your heart rate, not only what you feel as touch. And there are many other, these are actually blood pressure, not heart rate, but it's the same principle. Or in a completely different study, Maria Arzenova looked at learning. And when you learn, you often make errors. And that's what we call prediction errors. And you can operationalize this in some games during the learning. And interestingly, the feeling of not doing it right also correlates with a change in the heart rate. And in another study, another learning study, we had the same finding. A prediction error again was altered, was correlating with the cardiac changes. So it seems, and you can go through many thousands of other studies, that a cardiac deceleration, so a change in the heart rate, seems to be related to any kind of mental activity, and it seems to reflect some meaning. We call it metacognition, so like I'm sure about it, the social aspect of this touch, or sometimes we call this gut feeling. Now, in this picture of relationship between the heart and brain, you could say maybe the cardiac deceleration, so the decrease in heart rate, is kind of a top-down effect, goes from the heart, from the brain to the heart. Now, are there also effects that we could dissect in the other direction? So are there also bottom-up effects? Does the heartbeat itself influence perception and cognition? And that was actually quite surprising to me, and I want to explain this to you. It was detected by Pavel and Martin. What they did, I mentioned before, we did these tactile stimulation. Actually, these are little electrical stimulation. So you get an electrical, the British call it shock. It's not really a shock, but it's a slight tingling that you feel with an electrical stimulus. And then we measure typically whether people feel it or not, and we measure also evoked potentials in the electroencephalography. But in this study, Pavel just recorded simultaneously the ECG, the electrocardiogram. And so you probably don't know the electrocardiogram that well. This so-called R peak is when the heart contracts and then during this systole, the heart contracts, and then it relaxes, then it contracts again, then the heart relaxes again. So we call this systole and diastole, systole and diastole. And now we looked whether it makes a difference whether the stimulus was applied in systole early when the heart contracts or later in one heartbeat. So we are talking about 1 second from here to here. And lo and behold, we were very surprised. If people did not feel, this was typically in systole, and if the people felt the stimulus, so a higher likelihood of detection was in diastole. So the supervisor, me, was skeptical, so we repeated the study, Esra al, and she, lo and behold, found the same thing. We missed this, was more in systole, and hits later in diastole. And here you see again, systole, diastole, and it's a small difference, but it's clearly significant. And also Esra found that the evoked potential, which is, so with the stimuli, you have an evoked potential. And so if people had the stimulus later in diastole, the evoked potential differed, especially what a late component that we call P300 was stronger in diastole than in systole. So we not only have a difference in the feeling, but also in the evoked potential in the brain. Now, so there seems to be a difference in perception in short times, whether the heart is contracting or relaxing. And so we thought, oh, maybe the brain is overall more active in the diastole and not less active in systole. What about the motor system? And so in this study, Stella Kunzendorf, she asked people to start a game, a computer game, and they could start whenever they wanted. And she checked whether they more often started the game in systole or in diastole. Interestingly, they started it more early. They started the game more in systole. So we didn't tell them when to start, but if we record simultaneously the ECG, they just start more often in systole. So the other way around, as opposed to the perception. And so we asked ourselves, maybe can we measure the excitability of the cortex? Is that different in systole versus diastole? And that's again what Esra did. And to make a long story short, we found a clear difference. She did magnetic stimulation where you can measure the excitability, and she simultaneously recorded EEG. It's and ECG, so it's a quite difficult experiment. And she found a significant difference again in systole. So in systole, the excitability of the cortex is higher. And that just shows this effect again. So it seems that during each cardiac cycle, there is a patterned modulation of the sensory motor system. So the motor system is more active in systole, and the sensory system is more active in diastole. And actually, such alignment of performance not only happens during one cardiac cycle, but you can also measure this, for example, during one respiratory cycle. This is what Martin Grundegen did. I don't want to go into it, but again, during one cycle, he found different behaviors and different motor performance, again showing us that the sensory input into the brain and also my motor performance changes not only during each heartbeat, but also across one cycle of respiration. I don't want to go too much into this. So, but the summary is during each cardiac and respiratory cycle, there seems to be a modulation, a patterned modulation of the sensory motor system. Now, what about other aspects like emotions? Sarah Garfinkel has shown that in systole, emotion of fear is stronger than in diastole. So if you see a fearful face, you have a much stronger effect in systole than 400 milliseconds later in diastole. So it's amazing how big the differences are within half a second. And this is maybe the most worrisome finding. In this study, again, the group in London, they studied the presence of racial stereotypes. So they studied whether in this study people would associate a weapon more with a dark face than some tool, some not dangerous tool, or vice versa. And what they found is that during systole, there was a strong difference between white and black faces. So basically, there was a strong racist stereotype, which was not present in diastole, which is a very strange and worrisome finding. It seems to be related to emotions being stronger in systole versus in diastole. So what we can conclude is during each cardiac and respiratory cycle, there seems to be a functional modulation of widespread brain activity. Or as a take-home message, I have shown you now many different findings, but the main take-home message of this first part is all mental events that we measured seem to affect the heart. Heart goes up or down in heart rate and blood pressure and others. But in all cardiac activity, each cardiac cycle, but also respiratory activity, affects the mental. That's part one, the A of my first take-home message. And now coming back to this slide, I showed you that these interactions between the cortex and the body, they happen already within one cardiac cycle, so within milliseconds. So the interaction is better to be seen like a continuous change, like in these cogwheels. So basically, we think, don't go into this, we think of this integration like a continuous change in any of these, in the heart or in the brain or in the brainstem, will continuously affect the other. And therefore, we assume that there are tightly integrated neurocardiovascular states, which are part of overarching brain-body states. And so that's the second part of the take-home message. Integrated brain-body states underlie or go along with, if you're a bit more cautious, with all mental activity. And all mental activity basically are associated with integrated changes in the brain and the body. That's the first part of my talk. And I come now to the second part about going more into the clinic, cardiovascular and neuropsychiatric diseases. How do they come together? Now, as a neurologist, and if you, the heart and brain, many people talk about heart-brain interaction, and what typically is meant is something very dramatic and very important in neurology. So very simple, if the heart stops beating after 10 seconds, people are unconscious. And after only 2-3 minutes, there are already irreversible brain damage. And after 10 minutes, the brain is irreversibly dead. And that is cardiac arrest. And the other point is that the heart is often the origin of so-called emboli. If a thrombus exists in the heart, it will often spread into the brain and then produce a stroke. And these two types of cardiac heart-brain interactions dominate basically our thinking about the heart and the brain in neurology. And you can again see this, I strengthened the point of brain-body interaction, but here you can see kind of a direction from the heart to the brain, which is dominant. Now, is there also another direction of the brain to the heart? Yes, there is. It is well known in many cultures, this is a picture from the voodoo culture, that in some situations, a so-called death spell, so basically an important person in a culture says a death spell as a punishment, for example, and that just by mentioning this spell, people die. And I said this is there in all cultures. There are reports in all cultures that have been studied. Also in the Christian, just the first was voodoo. In the Bible, you will find the so-called death of Ananias. Ananias was doing some betrayal, and then Paulus put basically a death spell on it, and then soon later Ananias died. So in mythology and in many cultures, this notion is well known, and it was controversial whether this is a real thing or not. In the meantime, we have learned that there is an underlying disease that is well known, also happening actually quite often, which is what we call stress-induced cardiomyopathy, so-called Takotsubo syndrome. It was first described in Japan, and the reason why it's called Takotsubo has to do with the fact that during stress, a strong cardiomyopathy, a change, a degeneration of the heart happens, and then the heart has this, all of a sudden, this altered shape, which is similar to a Japanese octopus pot where they catch octopuses, and that's where it has its name from. And so, as I mentioned, it was first described in Japan. In the meantime, people know that this happens much more often. It's called the stroke heart, and that it's called the broken heart syndrome. And it interestingly happens mostly in middle-aged women after menopause. We don't know precisely why that is the case. And it's a significant percentage of the population that is affected by this. And interestingly, there is another disease which has a very similar effect, the so-called stroke heart syndrome. People who have a stroke, a lesion in the brain, yes, they have a paralysis or they cannot speak, so they have symptoms related to the brain. But then people noted that the people with a stroke often also have immediately also a problem with the heart, up to a cardiac infarction or a cardiomyopathy, similar to the broken heart. And more and more studies then have shown that this is especially due when the stroke is located in the anterior insula. And remember, the anterior insula is one of the regions that is involved in the regulation of heartbeat and blood pressure. And so we now think, and there's good evidence, that due to this lesion, similar to the broken heart syndrome, there is an overshooting, very strong activation, a sympathetic activation, which far too much challenges the heart, and that the heart can no longer match this challenge, and then becomes diseased up to a heart attack or a cardiomyopathy like in broken heart syndrome. So the main message here is the following: yes, in acute situations, when there is a very strong change in the brain during some stress in Takotsubo cardiomyopathy or the stroke heart syndrome, yes, then the heart can immediately be severely affected, and also the other way around. But now, before, in the beginning, I mentioned the relationship between cardiological disorders and psychiatric disorders, like anxiety, like depression. And this is not so well studied and not so clear. But if you remember what I told you before, that the relationship, or that the heartbeat and the cardiovascular system is regulated by areas involved in emotions, at least then you start thinking maybe there is some problem with this regulation that leads to the coincidence of cardiovascular disease and psychiatric diseases. Now, if you think of each heartbeat, then, and this is what I talked before, so you have a heartbeat and there's systole, and because the heart throws the blood out into the body, and then there's diastole, the blood, and during this time the blood pressure is high. If you go to the doctor, he will or she will tell you the blood pressure is 120 to 80, that is normal, and the one is the systolic blood pressure and the other is the diastolic blood pressure. And so the theory was born that this change in the blood pressure during each heartbeat is maybe also responsible for these changes in the mental and emotional function that I mentioned before. And this is supported by findings that if you directly stimulate those so-called baroreceptors that measure the blood pressure, if you do that directly, they produce also reduction of pain. They have a positive effect on emotional processing, and also they reduce, for example, tactile evoked potentials. Now, the question is if bottom-up effects of systole diastole, which relate to blood pressure, if they have so much effects, what about people who have an increase in blood pressure? For example, in the development of hypertension, is that also related to this baroreceptors effect? Or maybe it's even important for the generation of this disease. Hypertension is a very frequent disease. It affects more than 60% of the elderly population. Elderly, I mean above 50 in Germany and worldwide. And it's responsible for many, many other diseases like stroke, heart attack, dementia. So to know how this comes about would be extremely important. The most important risk factor for cardiovascular diseases. Now, what is the relationship between hypertension and mental health? And that's actually quite interesting. So first, we were a bit, the doctor candidate in my group, Lina Shari, who did the study, she first did a study which surprised us a lot, and we were almost shocked. We were shocked. So what she did is the following. I should mention our institute in Leipzig, we do literally thousands of magnetic resonance images, MRI, in healthy volunteers throughout the year. And in many of those, and we do it for fMRI, for many studies, but we also do structural images. And we also, in many of these participants, we know their blood pressure. And it's typically normal. And what Lina did, she simply correlated the brain structure with in young people between 20 and 35. In these young people, she just correlated brain structure with blood pressure. And the blood pressure was normal. And what you see here, or in what we call normal range, and what you see here is that people with a blood pressure of 130 to 90, which is assumed to be normal, but a bit higher, as opposed to people with lower blood pressure of 110. In these areas, they have decreases, they have atrophies of brain structure. So that already worried us a bit, because it means that already very early, maybe these people with somewhat higher blood pressure later develop hypertension. Very early, there might be structural changes, atrophies in the brain. And interestingly, we also noted that these changes already were seen in the widespread, but also very dominantly in the insula, again a region which is responsible for blood pressure regulation. And but if you look in the literature about the relationship between hypertension and mental health, it's quite interesting and it's very strange. So if you look into studies that relate well-being with blood pressure, they show higher well-being with higher blood pressure. On the other hand, if you look at depression and well-being in hypertension, then it's the opposite. And that's strange, because hypertension is based on the diagnosis of higher blood pressure, of chronic higher blood pressure. And so if you have higher blood pressure, you are better off. And if you get the diagnosis of hypertension, then all of a sudden you have higher rates of depression and lower well-being. So that sounds contradictory. And we termed it this hypertension mental health paradox. How can we resolve this? Again, Lina Schare wanted to resolve this, and what she did, she looked at the biggest study that's ever been done in human volunteers, the so-called UK Biobank. So they have investigated with a lot of parameters, including MRI and health parameters, more than 500,000 people. And she wanted to know what is the relationship between blood pressure, well-being, and depression, and hypertension and well-being and depression. And so she looked first at the relationship between systolic blood pressure and depressive symptoms, and well-being. And what she finds is that the higher the systolic blood pressure, the less depressive symptoms, and the higher the well-being. So that confirms one part of the paradox. And then she looked at the diagnosis of hypertension, and she confirmed the other part of the paradox. If people had a diagnosis of hypertension, then it was the opposite. So this did not resolve the paradox, it just confirmed both ends of the paradox. And now we looked at the people 10 years later, so because they have done a study, a 10-year follow-up. And I find it amazing. So your blood pressure 10 years earlier, if that is higher, you have higher well-being and less depressive symptoms. And if you had the diagnosis of hypertension, again, the other way around. So what is the interpretation of this? How can we resolve this paradox? And the first hypothesis that we had, that Lina had, she said, maybe it's a so-called labeling effect. So you go to the doctor and you feel fine because high blood pressure and hypertension in the early parts of the diagnosis, you don't have any symptoms. You go to the doctor and the doctor tells you you're sick, you have hypertension, and all of a sudden you feel worse. So this is a labeling effect, and that would explain this worse well-being just in a way as a reaction to maybe a bad communication or to just the knowledge of the diagnosis. But we have strong evidence that this is not the case. It's a bit complicated, but I tried to explain what our evidence is. So we looked at the longitudinal data, so people who basically were examined at one point and 10 years later. And we looked only at people who at the baseline did not have hypertension, they had normal blood pressure. And then when we knew what they had 10 years later, we could retrospectively see what the blood pressure was at baseline, and with those who developed hypertension and those who did not develop hypertension. And what you can see here is at baseline of those who later developed hypertension is a bit higher than those who did not. That is not surprising. So if you have a slightly higher blood pressure, and even if it's still normal, your likelihood of developing hypertension is higher. But then we found the following. If we adjust for the baseline, so if we say, we take a person who has a blood pressure of 120 and another person also 120, but the one of them gets higher blood pressure and gets hypertension, the other one not 10 years later, what happens then? So if we do not correct for that, if you just take these two groups, and at baseline there's no difference in well-being at depressing symptoms. But if we adjust for the baseline blood pressure, so if we look at somebody with 120 who later develops hypertension versus not, then you see a big difference. So at the same blood pressure, those who develop later hypertension have higher depressive symptoms, and at the same blood pressure, those who later, before the diagnosis, develops have lower well-being. In other words, it seems to be that it's not the labeling effect, but rather it's a predisposition of people who later develop hypertension. Most likely they need the effect of higher blood pressure for well-being, and on the long term, this leads to hypertension. So in summary, increasing blood pressure leads to higher well-being, and the diagnosis of hypertension is associated with less well-being and more depressive symptoms. That's the paradox. But the resolution is people with impending hypertension have a stronger association between well-being and blood pressure and more depressive symptoms. And corrected for blood pressure, people with future hypertension have lower well-being and more depressive symptoms. And that most likely leads on the long term to hypertension, or is one contributor. So they seem to need higher blood pressure for the same well-being. If this is the case, you should also see physiological and behavioral effects of a change in blood pressure. We looked at that, and I don't want to go, and people have found reduced somatosensory perception, they have found reduced perception of pain, also social pain. Social pain is less with higher blood pressure, lower stress perception, emotional dampening, and also in this study we showed that when you look at pictures with higher blood pressure, you rate bad or angry and sad pictures less strong than with lower blood pressure. In other words, there seems to be a physiological effect of blood pressure, which is in a way good initially, but on the long term leads to hypertension. Most likely, this is related to survival benefit with sympathetic activation. When you fight animals, when you have stress, then it's good to have a positive effect of higher blood pressure and higher heart rate. In our society, when these effects of transient blood pressure elevations and stress happen, when the iPhone rings, when you have a bad message on social media, when you give a talk or whatever. So you have so many new forms of stress that the negative effect of these rises becomes stronger. So, but the main point I want to make here, in the terms of the overall picture, chronic blood pressure and hypertension are associated with long-lasting mental and cardiovascular alterations. In other words, the disease, hypertension or blood pressure change, has a dimension in the mental, so it's associated with mental changes, and therefore we call this a neurocardiovascular state or a chronic brain-body state, which basically changes the view on hypertension as it's not a bodily disease, but it's a brain-body state. And now I described to you a disease which is typically seen as a bodily disease, which I now call a brain-body state. Now let's go the other way around. Let's take a mental disorder, or a disorder that we typically see as mental, and see whether it has somatic components. And the mental disorder, which is very frequent, as you all know, is depression. Is this a purely mental disease? Does depression involve also cardiovascular alterations? And to make a long story short, yes, it has massive effects on the cardiovascular systems, but they are often overlooked. We know that people with depression have elevated heart rate and reduced heart rate variability. So here you see it very strongly in many studies. This picture just shows you odds ratios, and in all these studies, if this is on the left side, this means that people with depression have lower heart rate variability, and so it's strongly reduced in major depression. don't want to go more into this. It's just conceptual. Interestingly, if you now treat heart rate variability, if you teach the people biofeedback on the cardiac thing, the heart rate variability, then this is beneficial, it has been shown to be beneficial in depression. So with a cardiac treatment, you can improve depression. And on the other way around, there are ways to treat depression with transcranial magnetic stimulation. And so you could argue, oh, this is this is a treatment on the brain, obviously, but it works only if you stimulate a brain region which also changes the heart rate. So it seems to be only when you activate so-called frontal vagal pathway, then the effect of transcranial magnetic stimulation is beneficial. So elevated heart rate and reduced heart rate variability, 3 proven therapies targeting the neurovascular system, HRV feedback, vagal stimulation, and also magnetic stimulation over the dorsolateral prefrontal cortex, they are affected only when they involve the cardiac system, so that people even have said depression is a cardiovascular disorder. I would not say that. I would say it involves both the mental and the cardiovascular, and like hypertension, it's associated with a long-lasting mental and cardiovascular alteration. So it's a long-lasting neurocardiovascular state or a brain-body state. So for 2 major diseases which affect millions of people, most people in Germany is affected by one of the 2. I have shown you how closely interconnected cardiovascular and neuropsychiatric diseases are. And finally, and the main message, the main take-home message from the second part is all diseases of the body have a mental dimension, and all mental diseases have a bodily dimension. I have shown you this for 2 very frequent diseases, but I could tell you the same story for all other mental or bodily disorders. And let me finally make a few conceptual remarks. I, in the beginning, showed you this tightly integrated, within milliseconds, neurocardiovascular states. And the tight integration on millisecond to millisecond is that we call microstate. This follows a study which I don't want to go into in animals, where people have described fear as a neurocardiovascular microstate. So it involves mental activity and massive changes in heart rate. And these microstates, brain-body states, they move on all the time. So brain-body states move in a certain, so here is the brain parameter, is a cardiovascular parameter, and other bodily parameters. In this 3-dimensional space, we move all the time. And if we have fear or happiness, we remain for a certain period of a few seconds, maybe a minute, in a microstate. Interestingly, and that has been shown, how these microstates happen is affected by the overall structure of our body, which we call macrostate. And in diseases, this macrostate is changed. So it's shifted, for example, in a certain part of the heart. So now this is shifted towards hypertension. The mental activity is different. And so the entire change in bodily states is shifted in a so-called macrostate. And in between, there are transient states, which we call mesostate, which, for example, a stress situation, which transiently changes our brain-body state. During stress, we have higher frequency of the heart, we have higher blood pressure, and we are a bit more active. But this disappears. So we have 3 types of brain-body states. The big picture, so the big structure in which everything moves. We have continuously changes in brain-body states, sometimes transient emotions or other bodily feelings, and then we have maybe for hours or days, we have transient mesostates, which also affect our overall body and mental activity. And so I talked about stress as a mesostate. Another mesostate is actually the menstrual cycle. Don't want to go into it, but you, I think it's very clear that during a menstrual cycle, women go through changes in the bodily as well as in the mental state, and but of course it's reversible and repeating during each menstrual cycle. Here you see so different kinds of microstates. They are reversible. Emotions is a prime example, but also decision-making, perceptions, mesostates. Stress is one, but also exercise, moods are longer lasting examples, and they all involve the body and the brain. And then macrostates, they are associated with structural changes. They are long lasting and they affect the mesostates and also the microstate. And so it can be that a repetitive mesostate can, on the long term, affect a macrostate and lead to diseases. And I want to illustrate this to you, and how, for example, a change, repetitive stress, which we know leads to stroke and heart failure and also to depression, can do this in this concept. So this is maybe the starting point. And then you have a period of stress, and this moves a little bit in one direction, the overall macrostate. You have another period of stress, it moves a little bit more. Of course, this is not just once, this is 1,000 times. And then over many mesostates, in this case, chronic stress, maybe unemployment and many other stressors. And in the end, the entire picture, the entire macrostate changes. And then if you just compare the healthy situation and the disease, like in this case, a strong depression, then all three bodily aspects, on the brain side, the cardiac side, the mental side, and the body side in general, they are affected via this long-term development as a macro state. So, in summary, brain-body states, that's a view on physiology, normal functioning, but also on diseases. Basically, it challenges the reductionist view on only one dimension. I think it has to be considered in physiology, but also in clinical states. We have to understand the inner working of these brain-body states for healthy behavior, but also for diseases. Especially medicine must consider all these dimensions for diagnosis and treatment. I think that things like mobile assessment of brain-body dimensions, like with wearables, can help us in some situations to diagnose micro, meso, and macrostates, especially when a mesostate moves to a macrostate or a microstate moves to a mesostate, and then help to intervene, perhaps. And then now I only talked about heart and brain, but of course there are other bodily dimensions like immunology, metabolic aspects, the gut-brain axis, social interaction. Of course, these are also very crucial aspects of brain-body states and have to be included in the overall picture. So I'm at the end. I wanted to challenge this dualist view. I hope I have convinced you that it's no longer that we have to overcome this view via brain-body states. These are the people who have done the work that I presented to you. And I thank you for your attention. And in the very end, just an advertisement. Every year we have a so-called Mind, Brain, Body Symposium, which takes place in Berlin. It's targeted at students like you, doctoral candidates and early postdocs. We have very famous keynote speakers this year again, and it's cheap. It's in the middle of Berlin, close to the Charité. And it's also online. We typically have 200 to 400 people, 200 in presence and another 200 online. You are happy to participate. It's cheap, so it's hopefully also affordable. And if not, tell me. We will make it happen. Thanks a lot.
First of all, thank you for very interesting insights. So I'm an ADHD patient and I'm treated with a methylphenidate. So this also affects things like blood pressure. Would you say is, especially in the beginning, more a shift to a mesostate, but it can also affect it in the long run? Because then I would think maybe it is quite an unhealthy approach if you think about it going towards maybe a maladaptive macro state if the higher blood pressure chronifies, right?
Yeah, I mean, it's also a brain-body state, or it's part of a, I mean, I should be in my formulation precise. So it's a contributor to a brain-body state. Definitely. And yes, it may be a certain disposition, and this disposition affects immediate behavior, and it also affects intermediate behavior like the mesostates, and it's associated also with long-term changes. Now, I'm not an expert on HHG, I have to confess, but if you take medication, this obviously again changes the overall mesostate if you just take it, so you have immediate effects or very soon effects, and on the long run it affects also the macrostate. I would be hesitant to say good or bad. It just changes. And so in principle, medication could also kind of stabilize a certain state, and it might not. I don't want to distinguish good or bad or anything, but I just want to say that it clearly medication affects all three types of states. Especially if you take it long term, it will also affect the macrostate.
Thank you very much. From what I see, there's still no questions, but I think there have been a few that I've sent to you prior to this talk.
Okay.
I can read them out. Also, you answered like most of them during your talk. So and just have me a look. Okay, here's one that is based on what it's all about, but goes more into immunology. Given that the SARS-CoV-2 virus is known to cause endothelial dysfunction and microvascular injury, could we expect progressive cognitive alterations? And if so, might individuals fail to recognize such cognitive impairments because these systemic changes develop gradually and continuously? So reinfection, and reshaping the baseline cognition?
It's well known that there are cognitive changes. There are also brain atrophies. They are most of the time subtle and most of the time also reversible. And whether they are related to endothelial dysfunction, possibly, but it's not proven.
Thank you very much. Then I would say, if there are no questions from the chat, I read out like one or two more, depending on your time, and then I would switch to our outro slides. So let's have me look. Could some form of vagus nerve stimulation used to activate the immune system in advance, so prior to general and severe infection, in the context of cytokine transmission and PAMPs via the vagus nerve?
Good question. It says some form of vagus stimulation or vagal nerve stimulation. There I would say maybe, not the forms that we use today. So, I mean, to do it in a there's one thing to just try to interfere with an ongoing disbalance. If you do it in a preventive fashion, I would be rather be honest, I would be doubtful whether one should do it in a preventive fashion. I mean, so if you want to do something in a preventive fashion, then try to improve your vagal activity long term, and that's just do a jog every morning or do a lot of sports, meditation, these kind of things. These have long-lasting effects on your vagal activity and have a lot of beneficial health effects. Don't go, I mean, vagal nerve stimulation is a poor replacement.
Thank you very much. So then for the last question, I think I have to add something. If so there's a question from Aska.
Yes, let me switch on my video. So thank you very much for the talk. So I have more of a general question, I guess. So I would be interested in your personal opinion on how these kind of heart-brain interactions, or in general mind-body interactions, should be taken more into account in areas of cognitive or affective neuroscience, because I personally feel like maybe I'm just missing a lot of research there that I haven't read, but I feel like it's something that is not regarded very often, not to say at all. And of course, if in a lot of like these affective or cognitive experiments, you have like a very stable environment with like where there probably aren't too many external stressors affecting results between participants. But I was wondering, like, if you have like any general thoughts on how or if this should be incorporated more, and if there's like any new developments towards that direction that are worth to kind of go into more deeply. Yes.
I think studies on emotions without looking at the body is no longer doesn't make sense much more. So I would be very strong, and I mean, it's no longer, it's mainstream now. I think that there are interactions between the brain and body which are highly relevant for the production of emotions and all parts of our thinking. That's no longer an outsider theory, but I think people like Ledoux, Julian Thayer. I think that many people are doing this. You might not have to do it in each experiment. No? I would not criticize somebody who has a specific question where they just look at a certain aspect. But for a general picture of emotional research, but also clinical research, I think we must consider all these aspects, and it's being done. It's being done. I see Lirim and Sena.
Yes, I might just go first, I guess.
Yes.
My question is regarding research I actually did regarding Thayer and Lane's model of neural-visceral integration just after Grossman gave compelling evidence that Mr. Porges was wrong with his polyvagal research or theory.
Yes.
And during my research, I was basically instigating what you did with blood pressure, just regarding heart rate variability changes, induced changes, basically under stress and under...
Say blood-brain barrier?
No, heart rate variability.
Heart rate, oh, okay. HRV, okay, good. Yeah. Okay.
And during my research, basically it was about the stress induce a difference in emotion recognition or the capability of recognizing emotions.
Yes.
And my research failed actually to prove this part, that a reduced heart rate variability would reduce the capability to recognize emotions. What I did realize after further considerations and further basically statistic analysis was that there were certain prolonged effects during the recognition task which caused these differences. And now what my question is basically, you said multiple times that these behavioral and cardiovascular effects in the body system happen in a rapidly fashion. But is this
happen in a
rapidly fashion, basically
yes,
fast? And do you think that these fast changes can actually be performed in behavior itself, like in an emotion recognition task, which obviously doesn't take one heartbeat but longer? And basically, is it a statistical problem we're dealing with, where a bunch of inputs might vary, and in the end, it's a, however you want to call it, a numerical addition of effects? Or
I mean, you also have, I mean, there are many different effects that you have caused. You have the fast effects, so it's very rapid, but then you have also the longer lasting effects, which basically develop over, I mean, the so-called mesostates. For example, if you have repetitive performing a certain task, then your cortisol will increase, and then you have a stress response. And the task and the stress will affect heart rate variability. Then you have heart rate changes. Then you have changes in, I always talk about heart rate and the brain, but then you might have changes in your glucose level in the brain. So you have many dimensions. And they might, in a specific task, even cancel each other. So, and in specific situations, if you measure 2 or 3 parameters, the relationship between the parameters might change either because of a mesostate developing or because of another dimension influencing. So I mentioned this experiment. This is an animal experiment by Tovote, a researcher in Würzburg, and they looked at fear in animals. And in animals, when they have fear, they have a dramatic decrease in heart rate, and they have this what they call freezing state of fear. But if they do the experiment for a longer period, after 20 minutes, then the same state of fear, the same neurons in the brain elicit fear, but then the heart rate is all of a sudden increasing and no longer decreasing. In other words, during one experiment or during a prolonged experiment, the relationship can completely shift because you have other interfering factors. But of course, I don't know your experiment that well, but this is one type of potential confounder that can change the relationship, and often it's interesting to look at that. Sometimes it's just a change during the time course of the experiment. Sometimes it's some other interfering factor, and that maybe these are then quite interesting points to investigate.
Okay, thank you very much.
I see Sena Karaduman.
Yes, hello, can you hear me?
I can hear you, yes.
Yes, thank you for the talk. It was a really interesting talk. And my question regards the dualism you talked about in the beginning. I studied psychology and now I'm studying medicine, and this is something I've been wondering ever since I started medicine, how to handle the psychological, emotional aspect when handling medical, physiological, bodily questions, where psychological or emotional questions are in most cases completely ignored, and even in my experience a little bit laughed at even in the medical field. And now with my background in psychology and therapy, and even I worked in a trauma clinic with a lot of PTSD patients, and I saw it firsthand how the emotional experiences affect not only the psyche but the body forever, for the whole life, and how many risks go with such traumatic emotions. And I'm just wondering how you, as a neurologist, I understood, handle this knowledge in the clinical practice. Was the question clear?
Yeah. I mean,
Yes,
yes,
yeah, it's a big
the question is very
question.
clear. The question is very clear. And now, sometimes I give talks and then I say that stroke is a psychosomatic disorder. And people are getting a bit angry because isn't it a thrombus? Isn't it? Yes, of course. And I mean, a better formulation is it's the end point of a psychosomatic development over many, many years. Now, how does it affect the work as a neurologist? Now, my personal point is, so I was many years a acute neurologist. So I was heading a clinic at Charité and the stroke unit. And in the acute clinical setting, when you treat a stroke, then of course there are things like thrombolysis, opening of vessels, and so they are very much in the foreground of what you do. But after this acute situation, then immediately comes the situation where you try to prevent things, where you try to understand how this could happen. And then it's very absolutely crucial to not only look at the physical bodily changes, but definitely you must also look at the psychological aspects. Because, for example, after a stroke, and stroke was a disease that I was treating many times, about 50% of the people get a depression. And if they have a depression, then they will not go, the rehabilitation process is terrible. So you have to deal with that. You have to find out why do they get it. You have to find out so how can I interfere with this? So that said, I must also say that the situation in the clinics is unfortunately such that there's far too little time to really take care of these crucial aspects. And just because, I mean, as you realize, if you are a medical student in the clinics, of course, it's about rapid diagnosis, rapid treatment, a lot of monetary aspects that are, and I mean, there are many doctors who do absolutely great work, but the circumstances make it often difficult. So I try to emphasize that one has to consider these, especially psychological aspects, from very, very early on in life, have to teach people how to deal with it, how to become more resilient. And when I say early in life, I mean you guys. No? So, I mean, you know, in the 70-year-old, somebody who has atherosclerosis and is obese, it's, I would not say too late, so you can do many things, but the preventive medicine is much more important to think of. So also smaller alterations in bodily and mental function to work on this very early on. That will also be helpful if another disease occurred. That would be my practical consequences. Now, after I have done a lot of acute neurology, now I'm doing by far mostly research. And so I'm privileged. If I see patients, I have a lot of time, but that is unfortunately not translatable to the general medicine, I have to say. Still, we have to fight for that. We have to fight for that. We have to fight for a more holistic medicine and a scientifically based holistic medicine. So I don't want to applause from esoteric theories. Everything is so no. Yes, also medication can be useful. Also, molecular biology is very useful. So it's not abolishing that, but it is to consider on a scientifically sound basis that all these things interact, and we must consider all of them.
Yes, thank you so much. It answered my question in a really good way. I loved the way you talked about the stroke being psychosomatic, and I see it the exact same way. And sometimes in my experience, when I was in contact with patients regarding psychosomatics, I felt that it was so hard to grasp and understand for the patients that a bodily dysfunction may be caused by something psychological, and that there's not a pill you can swallow, that there's not a program you can do, but maybe you have to reduce stress, maybe it's sleep, maybe the psychological unwell-being causes you to lead some sort of lifestyle that's not beneficial. And I sometimes I feel bad to, I don't know how to handle the patients when they can't even understand and don't want to hear that it's something psychological, something in their head, because they can't grasp it.
Yeah, so there is a societal stigma for everything psychological.
Yes.
And so sometimes patient groups want to have a, it's a bit cynical, they want to have a bodily diagnosis.
Yeah.
So because society values this much higher than and then a psychological. And this stigma we also have to fight. I think a lot of things have happened. So people talk much more openly about also psychological issues. We really, I think we are on a right track, but we by far have not reached the level where it should be. Completely.
Yeah. Thank you so much.
You're welcome.
So, and I think there's one more question. Considering the time, I would say it should be around the last question of the evening. So, Franziska.
Yeah, thank you for me too for the presentation. And I wanted to ask about the meso and macro states, because in my current studies, I learned a lot about the allostatic load model and the HBA axis, etc. And it sounded for me quite similar, like the wear and tear until it's like chronically not ruined or chronically sick afterwards. Is it similar, or would it fit in like the allostatic load model in this, especially in the switch between meso and macro state?
Oh yeah. Basically, yes. I mean, these concepts are very similar. I mean, the neurovisceral integration theory of Thayer, the idea of allostatic load by McEwen. Yes, these are similar concepts. So, we try to put this in a theory of these brain-body interactions in dynamical systems theory, which basically takes up all these different previous models. And so if you talk about allostatic load, yes, the idea of allostatic load is that you have all these reactions to external input, which impact your body and your mental state. And so in translated to the brain-body model, this is a transition from a meso state to a macro state, typically.
Thank you.
But this is a very simplistic translation, I should mention. Okay.
Yeah. Okay.
So with that being said, thanks to everybody who's here, and thanks to everybody who has been here, and especially thanks to you, Professor Vilringer. That was a very nice talk. So today EEG was mentioned quite a lot from time to time, and the next Neuro Talk Evening is about the frequency filtering and broadband time domain in EEG and also MEG signals with Andreas Wittmann from the University of Leipzig. So you might want to join again to learn more about that. It will happen on the 20th of November. And if you also want to have a more detailed look at the research from Professor Vilringer, you can look up the recording of this presentation that will be shared on YouTube. Network internally, or the slides also will be shared afterwards. And we have quite a few links. These are the links that I also talked about in the beginning, but in the end of this slide, there are also the extended links because Professor Vilringer was so nice. He basically shared all of his links with us. And yeah, if you want to have more detailed look into the network, what we do, other projects, events that happen, you can just scan the QR code right here or look up our website. And yeah, with that being said, Thank you very much. Have a very nice evening and see you around again.
Thanks a lot. Bye bye.
Bye bye.